Hello and welcome to the GHAPP MASLD Community Network with Erin Parkinson. My name is Danielle and I will be your moderator today. I'm joined here virtually by our presenter. There will be an opportunity at the end to ask questions live. If you have any questions, please wait until the end. I'll now pass it over to Erin.
All right, thank you so much. So nice to be able to be here today. Happy to have anyone who joined us. Today we're going to be talking about lifestyle modifications and MASLD or MASH. And again, I'm Erin Parkinson. I'm a nurse practitioner. I work in transplant and general hepatology in Tampa. Okay. So we'll start today with a case study. We have Albert. He's 65 years old. He has obesity, and he was referred to our office, say, for elevated liver enzymes. He also had abnormal imaging, and abdominal ultrasound was done. It showed increased echogenicity of the liver that was consistent with steatosis. So again, he's 65, he's Hispanic, has a BMI of 29. This is pretty similar to many patients that we see in our offices all the time. Hasn't drank since he was in his 20s, so no current alcohol use. He does have metabolic syndrome, so he has, type 2 diabetes, hypertension, hyperlipidemia. On physical exam, we can see some findings such as the central fat deposition, but he doesn't have any stigmata of advanced liver disease, nothing obvious for, decompensated cirrhosis. Some of his laboratory findings include triglycerides of 89, his HDLs only 41. He has an A1C of 7.2, so could be better. His ALT has been elevated for an unknown reason, for the past 3 years, about 1 to 2 times the upper limit of normal. And he's already had an evaluation for other causes of chronic liver disease, and that evaluation was negative. So, we're already suspecting, right? We have steatosis on imaging. He has cardiometabolic risk factors. We haven't found any other reasons for him to have steatosis. So it gives us a diagnosis of MASLD. And that's our metabolic dysfunction-associated steatotic liver disease. Our nomenclature changed. So let's start with one of our care pathways. We have various clinical decision tools now, and they've been updated to help guide us with the use of all these non-invasive measures of fibrosis that we have available to us now. So we're going to apply the MASLD AGA clinical pathway to the cases that we talk about today. So again, for Albert, we know that he's at risk, right? And so we'll start by calculating his FIB-4. So we're going to do that using his ALT, AST, platelet count, and his age. And we can see those listed there. So the FIB-4 is our initial risk stratification that we're going to use. And his came back at 2.22. And that indicates an indeterminate risk. And sometimes this is often what we get, so we can't tell for sure if is he at risk for, if he has advanced liver disease or not. So because it's indeterminate, we need another test, and we're going to hope that we have a FibroScan available to us in our community. So we fortunately did, and we obtained a FibroScan, and that gave us a liver stiffness measurement of 6.7 kilopascals, which indicates a low risk for him having significant fibrosis. So based on all of this, we can say that Albert has MASLD, and the intervention that he needs is lifestyle modifications. So we really need to, optimize everything that we can, and then monitor him. And he can be monitored really, we can repeat the FibroScan in, say, 2 years. And this is kind of that algorithm. So identifying our patients at risk, and this can be done by primary care, endocrinology, GI, obesity specialists. Everyone should be screening for MASLD. We collect our history, get our labs, we do our initial FIB-4 risk stratification. And again, he came in indeterminate risk. So then we go to our FibroScan, and less than 8 kilopascals is considered low risk. and he's going to need lifestyle modifications. So the MASLD continuum that we face, it starts as steatosis. A lot of people have hepatic steatosis. It doesn't mean that all of them will develop steatohepatitis, which is the inflammation associated with fat. But the steatosis, the fat itself, is reversible. And many people will progress to steatohepatitis, so inflammation because of the fat that then leads to fibrosis, which is the scarring in the liver. All of that is reversible if we can get rid of or control the things that are causing the liver disease. But unfortunately, some people will progress to cirrhosis, which is considered irreversible scarring of the liver. And these patients are at risk for hepatocellular carcinoma, and we know that can happen in the absence of cirrhosis in our MASLD patients and MASH patients. This is a combination, as many things are, of genetics plus the environment. So we know that there are some genes associated with MASLD and with the accumulation of fat, the PNPLA3. There's some hypothesis about how that, can increase oxidative stress, decrease the TAG hydrolysis. We have other genes that have been identified, but then we add in our environmental factors, right? So saturated fats, which increase inflammation. We have fructose, so our high fructose corn syrup, but like if I can do nothing else, I at least try to harp on people about that. So sodas, it's in processed foods, so many things that we eat that are prepackaged. And that increases oxidative stress on the cells. So with our MASLD, we have steatosis, then we get inflammation, which leads to MASH and can lead to cirrhosis. Add in dietary fats. All of these things contribute to the inflammation and the pathogenesis of MASLD. So our obesity pandemic, it causes type 2 diabetes. Obesity causes MASLD. This is a huge concern in the world, but particularly in the United States. And these are the things that we must control if we're going to get control of our disease. So the management of MASH, first thing we have to do are lifestyle modifications. So regardless of how we're going to treat this, if there are other medications, say for someone other than Albert, sure, but we have to change their lifestyles. And we know that, there's a balance between nutrients and energy, and, the imbalance for the development of MASLD or MASH. Central obesity is a major promoter of insulin resistance and pro-inflammatory signaling. And you can see these patients as they come into the office. It's just where the fat gets deposited, then it's more likely to be visceral fat. And fat is an organ in and of itself, and has its own actions and consequences. All right, so back to Albert. So we're going to start with some lifestyle modifications. So we ask him, first thing you have to do is ask, what do they actually eat? So what does their diet consist of? And if we need more specifics, we can do a diet recall. Sometimes that can be helpful. So when we question Albert, he explains that he really eats a very traditional Cuban diet. And this contains mostly, rice and beans, pork, corn, beef, and plantains. So how are we going to approach this? How can we discuss this with him? Just telling him that you need to change your entire diet and follow, say, a Mediterranean diet instead, that may not be practical. So much of what we do with around eating is also a social event. It's something that involves all of the family, gets everyone together. There's cultural practices that are important. So how can we tailor our recommendations for cultural preference? We have to think about food accessibility, socioeconomic status. Does he have food insecurity that we need to be considering? First we start with, what are you eating? And then maybe out of those options, how can we make better choices? So perhaps for Albert, one of the things could be, how much rice do you eat? Let's talk about, moderation for that. Let's talk about maybe trying to incorporate a little bit more of the lean meats into your diet. So chicken and fish, how can we incorporate that into your diet more often? And you can still have some of your Cuban food, but just maybe less often, or we alter the, recipes. At least he's telling us it doesn't seem that he's eating a lot of ultra processed foods, which those are the things that we know are really hazardous So I think that we can make some changes for Albert to improve his diet and hopefully help his MASLD. So again, lifestyle modifications, so dietary changes and exercise. It's the mainstay of MASH treatment, particularly prior to resmetirom approval. And for him, again, he's unlikely to have moderate or advanced liver disease. So this is the mainstay of his treatment. We know weight loss is directly linked to improved histologic outcome. So we know this based on biopsies of patients. 5 to 10% total body weight reduction, it can actually resolve steatosis. It can get rid of the fat, resolve MASH, meaning the inflammation and the steatosis, and it can improve the fibrosis because we know fibrosis is reversible. So it can exert anti-fibrotic effects on MASH. We have to go back to the genetics, though. So environment plus genetics, of course, is important in the development of MASLD, but it's also important in the treatment and the response to treatment. So the efficacy of diet and exercise treatment, it could be impacted by genetic polymorphisms. So of course we have the lifestyle risk factors, which is more of our Western diet, sedentary lifestyle, and then we're trying to incorporate things to counteract those. So those are things like the Mediterranean diet and exercise. So, just telling a patient you really need to exercise and change your diet isn't really going to be very effective. I've been told this in the past myself, you need to lose weight, you need to exercise. Okay, well, those aren't very specific goals. It's not very concrete information that I could take home with me and try to incorporate into my life. So I try to be very specific with patients, try to develop specific goals that are practical, that are measurable, that they can be held accountable for and can actually be incorporated into their life. All different kinds of exercise that we could recommend. Interestingly, the high intensity interval training, which seemed to be kind of a thing for a little while there, was not shown to be effective. And when we look at resistance versus aerobic, because a lot of patients will ask that, should I do weights or should I go on the treadmill? It looks like they're probably equivalent, but the resistance does require less energy consumption. So, really what we need is probably a combination of the two. And we can see what aerobic exercise does. We have activation of lipolysis, we have upregulation of certain things in the body, alteration of the cytokines, and resistance training has its own effects as well. The hypertrophy of type 2 muscle fibers, alteration in myokines. But really, for a MASLD-friendly diet, calorie restriction to achieve the weight loss is still our mainstay. Certain diets that promote ketogenesis seem to be effective. We do know that there is that genetic predisposition of, someone's response to a specific diet, although it's not really clearly understood. Now, it is supported by many of the organizations, including WASLD, as a Mediterranean diet. And that seems to be the primary lifestyle recommendation, is to follow a Mediterranean diet. Now, again, I can just tell a patient that, you need to go follow a Mediterranean diet, but they need more specific information. So we have, handouts that we give people, try to then go back to perhaps Albert's specific diet and cultural preferences, and let's see how we can incorporate more of the Mediterranean diet into what he's doing already. In terms of, the exercise, really what's, seems to be the most effective is recommending 150 minutes a week of moderate intensity exercise or 75 minutes a week of vigorous exercise. So, if we break it down, that's a doable amount if we break it down into a daily requirement. And it's probably a combination of resistance and aerobic exercise is what's needed and what's going to be most beneficial for these people. They can incorporate simple things into their lifestyle. Park further away when you go to the store. You know, have a step tracker either on your watch, you know, your smartwatch, or get something so that you can keep track of your steps, and it gives you at least something measurable and something that you can improve upon. So like, here's your steps that you've been getting every day. Let's increase it by 10% by the next time that I see you. You know, take the stairs instead of the elevator. Those things are going to be important. And the other reason that resistance training is important to add into that aerobic, you know, with weight loss, you usually lose about 1 pound of muscle for every 4 to 5 pounds of fat. And so we don't want, you know, muscle wasting to occur while patients are losing weight. So the resistance is important to maintain that muscle. Okay, so back to Albert. So this is our classic patient. You know, we counseled on lifestyle modifications. Maybe we gave him maybe we gave him like 6 months. Let's see how you do. Here are your goals that we'd like to see you achieve. And let's see. So he comes in for his routine follow-up, and of course, there's no improvement of his labs, which could happen regardless. But he does admit that he's not really started any exercise regimen. But he has been trying to cut out soda. So how do we create change, right? So we need a change in behavior, which is more challenging than just giving them, you know, specific rules to follow. Change in behavior and routine is always more challenging. So first we need to, you know, assess his motivation to change. I have some patients that'll just flat out tell me, you know, I love my bread. I'm not going to change. I'm going to continue to eat it. And there's only so much that we can do, but we can try to find maybe some other little changes in the diet that's going to make a difference. So we can assess his motivation to actually change. We can use motivational interviewing techniques, something that we would use even in our, you know, alcohol use disorder patients. But this is the same thing. We're trying to change a behavior, trying to change something that's, you know, really ingrained in this patient and their routines. Again, let's set some goals. So something very achievable, measurable that the patient also agrees on. It can't just be my goal. It has to be our goal together. And then hold them accountable to it. So he's been trying to cut out soda. So maybe the first thing we're going to say is, so let's eliminate soda altogether. You know, the problem with soda, of course, is the empty calories. It's the high fructose corn syrup that we know increases, you know, oxidative stress on cells and can lead to the formation of fat in the liver with inflammation. And that's part of these ultra processed foods. Like if we tell people, you know, the more ingredients something has listed, the more processed it is. If you can't pronounce the ingredients, that's also a suggestion that this is a processed food. We want really more like farm to table, you know, whole foods, which is expensive. So it's cheaper to buy processed foods. That's the way our country has these things in the grocery store. So we, you know, have to take that into consideration. But maybe for Albert, the next step is let's completely eliminate soda. You know, here's our goal by, you know, in the next month, we're going to completely eliminate soda. What else can we do that can make a small difference, small bits of change, you know, a little bit at a time. Something else that might work for Albert is intermittent fasting. Intermittent fasting has also been shown to be effective for weight loss. There's different kind of regimens out there, the 16 to 8, you know, 16 hours of fasting, 8 hours of eating seems to be effective for some, leads to about a 3 to 8% weight loss over 8 to 12 weeks. Stomach shrinks, so you don't end up eating as much at one time when you are allowed to eat. And it has been shown to improve MASLD. So there's some studies showing improvement in steatosis and in the stiffness, so on FibroScan or elastography. The long-term effects of intermittent fasting haven't really been shown. The gut microbiome we know is very important in MASLD, in addition to multiple other disease states in our general health. And we know that these ultra-processed foods disrupt the gut microbiome. So again, if we can focus on nothing else, let's at least focus on that processed foods, the sodas, the empty calories, and then perhaps something like the intermittent fasting would work for Albert. But we need him to have buy-in for this. Otherwise, you know, it's never going to work. So how else can we figure out if patients are actually doing what they say they're supposed to be doing? I mean, weight loss, of course, ultimately would be how we would assess things. We can look at their labs. In longer periods of time, we can reassess steatosis. We can quantify that on a FibroScan, reassess stiffness. But there's also things like this exercise and diet adherence scale. It's totally, of course, voluntary, but it's a questionnaire that patients can do at baseline and 6 months later. Apparently, there's 33 criteria that are checked to monitor daily exercise and calorie intake. So, of course, it requires someone to actually fill it out. I have not personally used this in my day-to-day practice, but at least it's a tool out there to try and determine how adherent the patients are to these interventions that we're trying to get them to incorporate into their daily lives. Okay, and I think that concludes the talk for today. I'm happy to take any questions.